Morning, everyone. Dr. Ajay Singh, Professor of Orthopedics. Today we'll discuss rheumatoid arthritis. Arthritis, as you all know, it's a condition affecting joint. Arthros stand for joint. Arthritis, normally in medical language, stand for any inflammation. So it is inflammation of joint. Now, what is rheumatoid arthritis? Rheumatoid arthritis is an autoimmune disease in which the normal response is directed against an individual's own tissue, including joint, tendon, bone, resulting in inflammation of structure of this tissue. Now, when we say that affect not only joints but it affects tendons, but what is the characterized? It is characteristic of this rheumatoid arthritis. It's a chronic disorder. It's a chronic and persistent synovitis, which leads to cartilage damage, and finally it causes joint deformity and leading to a permanent disability. How can you explain it? Let us say the knee joint. First, disease starts in the synovium. It progresses to the underlying bone. First, the cartilage gets eroded. First, the cartilage is destroyed, followed by the underlying bone, and then comes when the bone is destroyed. What happens? Deformity, say varus or valgus deformity. In rheumatoid arthritis, the valgus deformity is formed. So, this deformity can lead to a permanent disability or the function of a joint may be permanently affected. Now, let's start with the anatomy of joint and this further. Joint, as you all know, is made up of two bones. Let's consider knee joint. So, what are the bones involved in this? Femur and tibia, right? Yes, patella. So there is a synovial lining, which is called synovial membrane. Its function is the synovial fluid, which acts as a lubricant. This capsule, which is lined by a synovial membrane, and here, of course, ligament like PCL, PCL, discuss which acts as a shock absorber. And yes, there is a cartilage, which covers the long end of the. So what happens? This condition is firstly there is an inflamed synovial. What does it do? The inflamed synovial expands and starts engaging the cartilage, the joint itself. So once the cartilage engages the cartilage, there is a vasodilation. It's a rise of what we say is the mediators inside the joint and cartilage, and usually the cartilage is destroyed. And once the cartilage is destroyed, then the next is followed by the. Once the bone is destroyed, the subchondral bone is destroyed, the deformity occurs. The normal movement of joint is distorted. Let's say varus or knee joint. So coming back to the part of this, Can affect individuals of any age, but most commonly it affects third to sixth decade of. Is more common in females than males, and there are different variants. It can be polyarticular, oligoarticular, or what do you understand by the term polyarticular? It involves many. It's called polyarticular. Oligoarticular when it involves few joints. Or oligoarticular. It can be monoarticular when it involves only one joint. What are the characteristic features of rheumatoid arthritis? Patient invariably complains of early morning stiffness lasting for more than 1 hour, and which eases with the physical activity as the patient starts walking or morning walk. Disability or he or she starts with the daily activities of daily activity. It may ease up. Now the small joints of hand feet are typically involved, namely the metacarpophalangeal joints, the PIP joints. PIP joints, remember, is typically spared in order. This joint may be involved, and yes, of course, larger joint may be involved, but it more commonly affects the smaller joint. The clinical manifestation can be both articular and extraarticular. What do we understand by articular manifestation? That when the disease is limited to the joint itself. What do you understand by extraarticular manifestation? When the disease manifests itself outside the joint. The tendons and ligaments also get it. So the articular manifestations are typically it is pain and swelling in the affected joint, which is aggravated by. So the pain is the most common symptom, followed by the morning stiffness lasting for 1 hour, and commonly there are multiple joints which are, like I said, metacarpophalangeal, proximal interphalangeal joint, and MTP joints are involved in 90% of cases, followed by knee, ankle, and wrist, which are involved in 80% of cases, followed by shoulders, which are involved in 60%, and elbow joints and other joints which can be temporomandibular joint, acromioclavicular joint, and sternoclavicular. But other joints which we can easily forget is spine. Spine, yes, rheumatoid arthritis is more of a peripheral disease, but spine can be more commonly cervical, followed by thoracorumbus, sacroiliac, and are not that commonly involved, but yes, in very, very advanced cases can be. What are the clinical features of rheumatoid arthritis? To see this patient, examine the most commonly joint involved is the PIP and MCP joint. So always examine this joint. What you will see is the swelling. Okay? Sometimes painfully restricted movement, and yes, there will be some tenderness. And yes, of course, there can be deformity like quaternary deformity, swan neck, and ulnar deviation of wrist, swelling at the wrist. Now, what is the quaternary deformity? So it is flexion at the PIP joint and extension at the DIP joint and flexion at the metacarpophyllin. And remember what is the swan neck deformity? There is extension at the PIP joint and flexion at the DIP joint. So these are the different swan neck and bottleneck deformity. But remember, this deformity occurs at a very, very late stage. Extraarticular manifestations. Now coming to extraarticular manifestations, they are rare but can be present in 30 to 40% of cases. But remember, these patients are more likely to get high titers of rheumatoid factors, and anti-CCP can be HLA-D4 positive, can be common in male, and what is important is early onset of disability. What we have that is whenever there is extraarticular manifestation, there is early onset of disability. Whenever there is extraarticular manifestation, constitutional symptoms. So, then rheumatoid nodules. On hematological examination, what we get is homocytic anemia, leukocytosis, leukopenia, thrombocytosis. Is something called Felty syndrome. That is the chronic nodular rod arthritis, splenomegaly, and in respiratory symptoms we can see pleural effusion, pneumonitis, pleuropulmonary nodules, LD, CVS. They can be asymptomatic, pericarditis, pericardial effusion, cardiomyopathy. Blood vessels, there is something called rheumatoid vasculitis. There can be mononeuritis, multiplex cutaneous ulceration, digital gangrene, visceral infarction. CNS, there can be peripheral neuropathy, cord compression, can be atlantoaxial, mid-cervical spine subluxation, entrapment neuropathies. Eye, there can be keratoconjunctivitis, Zika, scleritis, and scleritis. These are some of the extraarticular manifestations which are commonly dealt by rheumatologists or orthopedicians. Overall comes when primarily in advanced cases, mostly in the joint. So how you identify such cases are extraarticular? Just by looking for some card. So we'll look for in the extensor surface of hands. It is best back is more common. And remember, it is marker of the disease activity. So whenever you get this nodule, that means that disease is severe and more likely the patient will end up with a permanent disability or disability, or we need a joint placement at an early stage. So how will you evaluate these cases of rheumatoid arthritis? Yes, of course, we'll order some lab investigation data like complete hemogram, ESR, CRP. Look for acute phase reactant, CRP, ESR, rheumatoid factor, anti-CCP antibodies. So rheumatoid factor, the antibody diet to recognize FC portion of it can be also IgM and IgR. Now, not all the patient of rheumatoid arthritis will have these RA factors. Only 85% of this will become RA factor positive, that too after 2 years of disease. So, patient who is strong suspected rheumatoid arthritis and RA factor is negative, please get a RA factor done, repeat after 6 months. But yes, a positive RA factor means a poor prognostic value in terms of more extraarticular manifestations, more joint deformities, and more disability. Now, it can be positive in some other cases like Sjögren's syndrome, vasculitis, sarcoidosis, SLE, cryoglobulinemia, chronic liver disease, and in some infections, malignancies. It can be spontaneously positive in old age, for 60 years. Anti-CGP antibodies is IgG antibodies, which is directed against synovial membrane peptides. It is 65% sensitive and but 95% specific. It has got both diagnostic and prognostic value. It predicts the erosiveness of the disease severity, and poor functional outcomes. Acute phase reactants, which can be positive, are serum celloplasmin, C3C4 complement, aptoglobin, KSR, and remember that CRP will be markedly elevated in acute. Other lab abnormalities which you should look for is thrombocytosis, leukocytosis, DNA, inflammatory synovial fluid, hypertrophy. Now, next investigation, we advise more is radiographic investigation. What we look for is periarticular osteopenia, uniform symmetric joint space narrowing, marginal subchondral lesions, joint subluxation, joint destruction. Ultrasound, it is helpful in detecting early soft tissue lesions. Now, MRI has greatest sensitivity to detect synovitis and marrow changes. Now, here are some diagnostic criteria. A person shall be rheumatoid arthritis if he or she satisfies 4 out of 7 criteria, with criteria 1 to 4 present for at least minimum of 6 weeks. Now, as per ACR diagnostic criteria found in 1987, these criteria are morning stiffness, arthritis of 3 or more joint, arthritis of hand, symmetric arthritis, rheumatoid arthritis, serum rheumatoid factor, and perfect changes. Now coming to the management part, early management spaces. The focus of management is on pain relief, preventing or limiting the disability or damage, patient education about the disease, physical therapy, occupational therapy. Treatment should be started early. Mainstay of the treatment is NSAIDs, steroids, disease modifying agent, immunosuppressive therapies, we can give biological therapies, and surgeries like joint replacement. Now, NSAIDs are mainstay of treatment for pain relief, but we should prefer selective COX inhibitors like atopic because these patients they need pain relief for longer. Now, steroids are fairly commonly used in this condition, but there are indications for use of steroids. This used more commonly in extraarticular rheumatoid arthritis whenever vasculitis or interstitial lung disease. It acts as a bridge therapy for 6 to 8 weeks before the action of disease modifying agent starts. And in cases of active disease. And sometimes the steroids can be given in pregnant women, which DMARDs are not used. Disease modifying anti-rheumatoid agents are the drugs that actually alter the disease course, should be used as soon as diagnosis. Appearance of benefit delayed for weeks to months, that is why steroids are started. NSAIDs must be continued them until true remission is achieved. What are the DMRDs? Methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, such as some of the used. Some of the less commonly used are chloroquine, gold, cyclosporine, penicillin, minocycline, from this. Methotrexate usually given a dose of 7.5 to 25 milligram once weekly works well. So some of the common side effects are AE upset, hepatotoxicity, suppression. But it usually takes 1 or 2 months for onset to start action. So at that time, you can give steroid first. Other drugs like sulfasalazine and fluoride have also onset of 1 or 2. Now, in which patient DMRD should be given? It should be given in all the cases in which simply NSAIDs doesn't work for after giving 3 months. But 3 months is, remember, it's arbitrary period, simply chosen because most of the patient will automatically go into remissions after 3. They should be chosen carefully. Methotrexate has rapid onset but has side effects. So it should be chosen with taken into patient tolerance, cost consideration. But methotrexate is DMRD of choice and most studied. Sometimes it may be combined with leflunomide because of the synergistic action. But there are some patients of DMRDs, the onset may take several months. They may cause a partial remission only. They may lose efficacy with time. At time, immunosuppressive therapy may be considered. Most commonly used immunosuppressive therapies are cyclosporine. So recently, the biologics blood arthritis have found blood because the cytokines like TNF, 10 are key mediators of immune function. So this gene inhibitor like rituximab, that's relevant, quite effective. IL-1 receptor antagonist, IL-6 receptor antagonist, tocilizumab, anti-CD28 antibody, rituximab, T-cell inhibitor, Retacept are all very, very effective, but yes, the cost factor. Some of the surgeries which are useful are arthroscopic or consignotomy. Consignotomy causes disease, so arthroscopic signoid. Consider total joint displacement, particularly in the knee, hip, and waist can cause nerve entrapment. For removal of a symptomatic blood condition, but they are rarely good.